My name is Kristen Mari, and I'm a professor in the department, and it is my privilege to be able to moderate this session and welcome all of you Master's Essays presenters today. So without further ado, because there are more than the usual number, let's begin. So I'm going to invite Kayla Lin to get her slides set up. Kayla has a Bachelor of Arts in Biology from Occidental College, and her area of interest is focused on maternal, fetal, and perinatal health. And she is going to present a longitudinal qualitative analysis. So Kayla, I will let you take it over from now.
Great, thank you. Hi, everybody, and thank you for coming to our master's essay presentations. I'll be presenting my master's essay titled Protective Factors That Mitigate Change in Family Mealtime Routines During the COVID-19 Pandemic, a Longitudinal Qualitative Analysis. Okay. Some quick research background and study aims. Family rituals and routines are classified as having effective communication, minimal time commitment, and regularly repeated patterns. Family routines are necessary during times of uncertainty, as it shows the family's ability to collaborate, accommodate, and cooperate, especially during times of uncertainty, like the COVID-19 pandemic, which showed an increase of socioeconomic hardships, employment instability, food insecurity, and limited access to financial assistance, and overall increase of healthcare expenditures. And this was further exacerbated across racial and ethnic lines. More specifically, family mealtime routines are associated with positive health outcomes, as it's been able to increase family cohesion through guidance and role modeling of healthy behaviors and helping the child develop positive relationships with food. Family mealtime routines have also shown to have a protective effect on obesity, disordered eating, illicit drug and alcohol use, violence and delinquency, psychological well-being, depression, self-esteem, and overall academic achievement. This study aims to utilize the family stress model to identify barriers and protective factors for maintaining family mealtime routines using data collected from the COVID-19 family study. This is the COVID-19 family study's adaptive version of the family stress model. The family stress model shows that the decrease in socioeconomic status can affect child wellness and overall family processes. It's able to depict that economic and resource changes are associated with policies and the psychosocial pathway and helps identify overall protective factors. The COVID-19 family study was a prospective observational cohort study where the research group was able to maintain rapport with participants from 2 prior intervention trials that were paused due to the COVID-19 pandemic. Those trials were titled Creating Healthy Habits Among Maryland Preschoolers and Wellness Champions for Change. From there, they were able to enroll 697 families, and using a mixed methods design, they invited caregiver and child dyads to complete a survey, and following survey completion, were invited for a follow-up in-depth interview. These surveys and interviews were collected over 3 time points from 2020 to 2023. This study is a longitudinal qualitative design. We used 19 caregiver interviews from the COVID-19 family study, following exclusion criteria of the caregiver living with the child and completing an interview at all 3 time points. These interviews were mainly focused on family mealtime routines, specifically focusing on dinner time. Following transcription and anonymization of these interviews, inductive and deductive coding was done, and then following that, a thematic analysis was completed. The thematic analysis showed results that showed changes among the various time points. From pre-pandemic to the early pandemic, we found overarching themes of more time together for meals. This came from caregivers reporting that remote work flexibility and having the whole family inside the home allowed for more consistent family mealtime routines and overall ease of evening routines. We also found an overarching theme of less time together for meals. Some other caregivers responded that there was an inconsistent work schedules due to the COVID-19 pandemic and overall less caregiver participation in family meals, leading to a decrease of these mealtime routines. From the early pandemic to the mid-pandemic, we found another overarching theme of an increase in activities. This came from reports of caregivers reporting that their work schedule where it was originally remote work, shifted to back to in-person work schedule. This, in addition to child's going back to in-person school, and the overall start of extracurricular activities had then led to a decrease of these consistent family mealtime routines. On the contrary, we also saw a continuation of remote work where caregivers who prior who at prior points were unable to have a remote work schedule were able to then shift to a remote work schedule, in addition to some caregivers reporting a new focus on wanting to have healthier eating habits, led to an increase of consistency of those mealtime routines. Lastly, through the mid-pandemic to the late pandemic, we found one last overarching theme of a return to normal, which meant changing routines once again. A lot of caregivers responded that they had returned to a lot of their pre-pandemic routines, as well as having a decrease in overall consistent family mealtime routines. This mainly being due to an increased participation in activities and extracurricular activities, as well as caregivers responding that they had no more hesitancies surrounding the COVID-19 pandemic, mainly due to everyone in the family having either caught COVID-19 or had received the COVID-19 vaccine. Our thematic analysis also showed changes over time across all 3 time points. We found an overarching theme of consistent family meals, and this came from caregivers reporting their own personal importance and emphasis of having consistent family meals. And this was seen through practices of having a sit-down meal together, whether it was a home-cooked meal or it was takeout, but having a designated spot at a designated time to eat together as a family. The child having limited screen time during dinner, as well as having increased child involvement. And this looked like the child helping with grocery shopping, voicing their opinions on what they wanted to eat, meal preparation, cooking, and helping clean up after dinner. We also saw an overarching theme of consistent lack of family mealtime routines. And this came from caregivers reporting that they had no structured mealtime routine at the very start, at the pre-pandemic, and this persisted across all 3 time points. And this also came from many reports of caregivers noting that there were differing diets among family members. The child reported that they were not hungry when the caregiver had the food prepared at a set dinner time. And also caregivers reported that the age of the child really warranted their own food autonomy, and what the child wanted to eat and when the child wanted to eat is solely up to them. So some take-home messages and implications. Our results were able to identify some best practices for consistent family mealtime routines. And this was shown with having a set dinner time schedule, being able to have limited screen time for the child, and an increased child involvement in the overall family meal. We were also able to identify that inconsistency for some families is consistency. For caregivers who also reported that they had an increased amount of extracurricular participation. And while we also recognize that not every family can have a consistent dinner time, it is also important for families to be able to have at least one meal all together as a family. From here, we were also able to identify a number of protective factors, which included remote work and work from home flexibility, those extracurricular activities, as well as economic impact payments. This could later inform future policy recommendations, given as many caregivers were able to report an increase in consistency of these family mealtime routines, given their remote work flexibility, as well as most families who received the economic impact payments throughout the pandemic were able to report a relief of financial burden. The results from this study can also point to future research regarding the impact of various feeding practices on mealtime routines. It is considered a best practice that a parent and caregiver do not force a child to eat when they do not feel hungry. However, it is also a best practice to have a very consistent mealtime routine. And so these various feeding practices on child development, the balance between these feeding practices may lead to a point of interest in the future. We would also be interested in the impact of rebuilding routines after a temporary break. Child participation in extracurricular activities have been known to be very beneficial for social-emotional and physical and mental development for the child. And so having a structured routine and then having a major hiatus in between could later lead to a very interesting effect on child wellness and overall family processes later on. Finally, future research could point to looking into the effect of maintaining new routines, as many of our families and many caregivers reported that they went back to their pre-pandemic routines and not really maintaining the routines that they developed during the COVID-19 pandemic. This could be interesting regarding other families who, if they were experience another major time of uncertainty, if they're unable to then return to their pre-time of uncertainty routines and what that would look like regarding their child development moving forward with a new routine. So the study has a number of strengths and limitations. To start, this study used a longitudinal qualitative design, which used in-depth interviews. And so this allowed for a very good inside look for before, during, and 2 years post-pandemic. It allowed for a greater depth of understanding of family mealtime routines and why they changed over time, as well as allowed for better understanding of the other mechanisms, pathways, and relationships of mealtime routines and also best practices. Some limitations, though, with our major use of qualitative data, it does leave the study susceptible to recall bias as it relies on caregivers' ability to recall mealtime routines and protective factors that they received and perceive as important. Furthermore, this study was mainly conducted in the state of Maryland, so it could limit the generalizability of the findings as well as the overall retention of the study, which had 38 caregivers completed an interview at our first time point, but only 19 caregivers completed an interview across all 3 time points. I would like to take this time to acknowledge my reader, Dr. Erin Hager, my co-authors, Janny Din and Rachel Deitch, the researchers and participants of the COVID-19 family study, and my fellow researchers of the Strong Research Group, Nan Dow, Elise Kowalski, and Raquel Arbeza, as well as my academic advisor, Dr. Kristen Mari, the PFRH department, and my wonderful friends and family. Thank you so much for listening. Do you have any questions for me?
Wonderful. Thank you so much, Kayla. This was so interesting. So I'm going to help you with the questions. So I want to just emphasize that students have priority first, and you can either type in your questions in the chat or feel free to unmute yourself if you want to raise your hand to let me know. So again, if students have questions, this is your time. Kayla, while we're waiting for a question, I have a question. So I'm wondering, did you get a chance to look at how these themes varied by the household characteristics? So like if they had mainly adolescents versus younger children, or was it two parent versus one parent, that kind of a thing.
Yes, we were able to look at the various demographics, given that the 2 prior studies did include a little wider age range. For some of the themes regarding, say, the inconsistent mealtime routines of families reporting that the age of the child now warrants their kind of own food autonomy, those were mainly due for the families who had older adolescents, kind of high school age or middle school age.
Yeah.
And that wasn't always seen for, of course, younger children that were in elementary school. But overall, a lot of these themes were pretty consistent across households. So majority of the time, we didn't see too much of those discrepancies, whether it was a 2-parent household or 1-parent household or having multiple children in the house as well.
Great. Thank you. Other questions? Okay, then I'll ask faculty. Any faculty have a question? Others? All right, Terry, yay.
Hey, Kayla, thanks so much. Yay, congratulations, you did it. I am curious more about the experience. I don't know if this was your first qualitative analysis project or not, but I'm wondering how this differed from what you expected, or was it consistent with how you thought this process would go? I'd love to hear about the experience of doing this qualitative analysis with the team.
Yes, so actually this was my first qualitative analysis. So it was very interesting, very exciting to find and read through a lot of transcripts, but also being able to have that experience of having, qualitative data and reading a lot about these experiences and getting that really in-depth look of seeing the pathway of these caregivers, being able to follow them for 3 years was very, very interesting. And I feel that not many research studies are able to also have that experience with their really strong rapport with the research group. So that was really interesting for me. But yeah.
Great. I think we have time for one more question. Otherwise, Kayla, you can read the chat because a lot of people are just giving you a thumbs up and great job. So, okay, Cynthia, yay.
So great job. So I'm curious, like, do you feel based on your findings that you might think about, like, what advice should we be giving parents? Like, I think about anticipatory guidance and prevention. So when families are going through shocks, whether it's COVID-19 or something else, and knowing the importance, as you stressed, about meal routines, is there something that, in supporting parents that we should anticipate and prepare them to think about while they're dealing with whatever the, of course, larger issues might be?
I think it's also very important to recognize that it's also very different for various families and different households, but as well as a lot of our findings regarding the best practices of making sure that having like a sit down time for a sit down meal with everyone. It doesn't have to be dinner time. It could be breakfast or it could be lunch, but having that sit down meal time is very important for overall family cohesion and communication, and really helps build a lot of those social emotional skills from parent to child or caregiver to child. As well as having limited screen time, which is difficult in this day and age now that screen time is very much evolving, but trying to emphasize a decrease in screen time during dinner or during that meal time so that there can be a lot of that intercommunication among family members, as well as having a lot of increased participation of the overall meal time. So like allowing the child to have little opinions about what they want to eat, or being a lot more involved in being able to have a little more autonomy will help also help bolster those relationships between caregiver and child, but also really help them have that really positive relationship with food, of like knowing what they like, what they don't like, or where they can go buy it, and how to cook it and how to prepare it, which will really help them develop those healthy eating patterns and healthy eating habits later on in their life.
Great. Thank you so much, Kayla. This was so interesting. So next we have Malique Webb. And Malique, if you want to pull up your slides while I'm introducing you, that would be fabulous. But Malique has a Bachelor of Science in Public Health Science from St. Augustine's University, and her area of interest is maternal, fetal, and perinatal health. And she is going to be talking now about long-term health impacts on severe maternal mortality. So Malique, you can take it away.
All right. Thank you so much. Good afternoon, everyone. My name is Malique Webb, and the title of my presentation is Understanding the Long-Term Health Impacts of Severe Maternal Morbidity. A scope in literature review, and my reader is Dr. Farah Qureshi. So for this study, data ranged from 2005 to 2025 in hopes of acquiring enough data for a detailed review. So my results were not surprising, and it is something that I do hope to continue, my research in, and possibly to focus on one geographical area. So before completing my undergraduate in 2022, my advisors shared the importance of having more minorities advocating for women's reproductive health. She made mention at that time about an athlete who had experienced physical health complications at the time of their pregnancy, which leaves me questioning the impact and how it affects her lives after. So as an introduction, the health exposure in this study is severe maternal morbidity, which will be referred to as SMM throughout my presentation. The definition of SMM has evolved in a way that is defined as a life-threatening complication that arises during or after childbirth, which can have significant and lasting health consequences for mothers. Specifically for my paper, I tried to focus on the psychological and physical effects. SMM is important as it affects approximately 50,000 women a year, just alone in the US, an indicator of the quality of the healthcare system. This search showed me that most work has looked at the impact of maternal morbidity at the immediate health outcomes, and I was interested in looking at outcomes beyond 1 year postpartum with SMM as the exposure. Therefore, my search led me to the research question: what are the long-term health impacts of severe maternal morbidity? I used two theoretical frameworks: the life course perspective, which recognizes how early life events and cumulative exposure, like SMM, can shape long-term health trajectories. Additionally, the biopsychosocial model guided the approach to understanding how physical, psychological, and social factors interact to influence women's recovery and well-being after childbirth complications. This scoping review began in December 2024 and was guided by the Joanna Briggs Institute framework, where the focus was on the long-term outcomes of SMM, including the search terms listed here. To find and focus on SMM as the exposure, these inclusion and exclusion criteria were implemented. Using the search strategy on the previous slide, Covidence was used as a systematic review tool to generate these results. Using the search term, 342 potential articles were found. However, many of these studies did not meet the criteria. And even after reading through a few of the articles, they had to be omitted because of the study design. So 11 studies were reviewed from the initial pool of 342, covering diverse regions like the US, Canada, Brazil, and beyond, all focused on outcomes at least 1 year postpartum. Key findings show consistent links between SMM and mental health issues like depression, anxiety, and PTSD, with higher rates of psychiatric care in areas like the US and the UK. Physically, women in Brazil and India faced serious long-term complications like sterilization, kidney failure, and even maternal death. Quality of life was deeply affected, especially in Zanzibar, where social and emotional impacts persisted up to a year. And these were worse for women with fewer resources or more children. So this table summarizes some findings from major studies across several countries on the long-term effects of SMM. Mental health outcomes were a dominant theme, as women with SMM had significantly higher odds of depression, anxiety, PTSD, and psychiatric hospitalization, seen in the studies from US, Sweden, and Canada. Physical and reproductive health impacts included higher risk of sterilization, dialysis, and cardiovascular complications, especially in Brazil and Canada. Now, these studies from Tanzania highlight how SMM affects women's quality of life beyond physical recovery. One study showed that lower income, education, and higher priority were linked to poorer quality of life. The other found similar results, reporting long-term physical, emotional, and social challenges, especially for women with lower perceived wealth. Overall, quality of life declines were more pronounced in marginalized groups, reinforcing how the socioeconomic factors deeply shape recovery. Women who experience SMM often face persistent mental health issues, like, as I said, depression, anxiety, and PTSD, many of which go unrecognized. Physically, they're at a higher risk for long-term complications such as heart disease and kidney problems. As such, SMM can be seen to disrupt fertility, early maternal bonding, and delay breastfeeding and caregiving. These physical and emotional challenges can make it hard to return to work or care for other children, leading to financial stress and other burdens. Social isolation is common too, as many women feel stigmatized or misunderstood. Most concerning, though, is the gap in follow-up to care. Many don't receive the ongoing support they need after such a traumatic experience. These themes show that SMM's impact goes far beyond childbirth and demands a more holistic and long-term approach to care.
Right. Well, that's wonderful.
Some key takeaways from this review are that there's a major gap in research beyond the first year postpartum. Most studies focus on immediate outcomes, leaving long-term effects underexplored. Many women affected by SMM are not consistently seeking care after discharge, often due to the lack of follow-up, emotional distress, or barriers in the health system. SMM can influence family planning, as many women delay or avoid pregnancies due to a fear or ongoing health issues. These findings point to the need for better surveillance, standardized definition of SMM, and comprehensive postpartum care that addresses physical, mental, and social needs, especially for the higher risk groups. Some strengths are that This study benefits from a global scope, including data from diverse countries. It focuses on long-term outcomes, specifically looking at impacts 1 year postpartum or more. The review is comprehensive, covering not just the physical, but also psychological and social consequences of SMM. It also combines quantitative and qualitative research, providing a broad view of the issue. However, there are some challenges, including an inconsistent definition of SMM, making the comparison difficult across studies. Additionally, while mental health outcomes are important, there's a lack of long-term data in this area. Marginalized populations are often underrepresented, and there's heterogeneity in outcomes across countries and healthcare systems, which can affect the consistency of findings. In conclusion, this study shows that SMM isn't just a one-time event. It has lasting effects on women's mental, physical, and social health. Using the life course perspective, it shows how trauma accumulates, influencing chronic disease and future outcomes. The biopsychosocial model reminds us that women's recovery is shaped not only by medical care, but by social and psychological support. What does this mean? We need to treat maternal health as a lifelong health screen for mental health, monitor chronic conditions, and ensure equity in follow-up to care, especially for marginalized populations. Well, that concludes my presentation. I would like to extend my deepest gratitude to Dr. Qureshi for her unwavering support and encouragement throughout this journey. Her guidance has been instrumental. And I would like to also thank Sally Safi, whose introduction opened the door for this collaboration with Dr. Qureshi. And lastly, I would like to thank my family and the PopFam department for their support during what has been a life-changing experience, both professionally and personally. My references are on the last slide, and I will open the floor to any comments or questions. Thank you.
Thank you so much, Malique. This was so interesting and so informative. So yeah, really appreciate this. So again, I will open it up for questions, and starting with students first. Feel free to type in your questions or raise your hand. Okay. So far, no student questions. I do have a question while we're waiting. So I was really interested in when you started off your search, there were quite a number of studies that didn't make the cut, and you were talking about the study design. I'm wondering if you could talk a little bit about what that means. Why were so many studies discarded?
Well, so for one thing, that was a great question. Thank you. For one thing, I was more interested in looking at 1 year or more postpartum. So for example, like the cross-sectional studies that only looked at early postpartum, those had to be omitted since I was looking at 1 year or more. So
Gotcha.
any studies, yes, any studies of that caliber would have been omitted.
Okay.
I have a question as well. Thank you so much, Malique. You did a wonderful job. It's been awesome working with you over the past few months on this. I think that question that Kristen raised about the time frame is a really important one. So could you speak more about basically the timing of these studies? Like, what was the average kind of follow-up, and if there was kind of a gap in the literature as it relates to a longer follow-up, where would you focus if you were doing a study in this area that had a longer follow-up, where would you focus on your attention on first, given what you learned?
Yes, sure. Thank you. That was also a great question. I think the mean years range between 1 and 3 years, based on what I've seen from most of the articles. And if I believe one of the gaps with the follow-up times, a lot of individuals were lost to follow-up. Or a lot of persons, they just didn't continue. So of course, yeah, they were lost to follow-up. And well, based on what I've seen, I would probably keep the range I would keep it at 1 year postpartum. Anything beyond that, it poses a risk for people to be, dropped from the study, or not interested in, or actually, people can be lost to follow up. That's my main concern with a gap. So I would definitely keep it 1 year. However, it might be a little bit tricky given that, as stated, a lot of these mental or physical effects or impacts, they don't normally show up early on. So having it at 1 year, between 1 year and 3 years, based on the mean, that would be the best follow-up time.
Great.
Thank you.
Okay. I think we have time for one more quick question. Okay. I think time's up. So Malique, thank you so much for your wonderful presentation. Really, really well done. And now I'm going to call Chamini Welikala. Chamini comes to us from actually right around here. She got her degree in a Bachelor of Arts in Cultural Anthropology, Biological Sciences, and Sociology from the University of Maryland at Baltimore County. And her area of interest is maternal, fetal, and perinatal health. And she is going to talk about breastfeeding, I believe. So, Chamini, why don't you go ahead and share your screen?
Perfect. So hi, everyone. I'm Chamini Welikala, and I did a systematic literature review on the relationship between breastfeeding practices and the morbidity and mortality among HIV-exposed infants in low and middle income countries. So to start with, just a bit of context on breastfeeding. Breastfeeding offers significant health benefits both for infants and mothers. It has been shown to reduce infant morbidity and mortality by protecting against infections like diarrhea, pneumonia, and otitis media. And this is in addition to the cognitive and psychological and physiological developmental benefits, which is vital for long-term child health. For mothers, long-term breastfeeding also lowers the risk of obesity, diabetes, and some cancers, such as breast cancer. In terms of HIV, exclusive breastfeeding during the first 6 months is associated with lower HIV transmission rates when mothers adhere to antiretroviral therapy. And going forward, I will be referring to antiretroviral therapy as ART, which reduces the risk to as low as 1%. However, in the context of HIV, complexities and disparities exist between high middle income and low and middle income countries. Generally, in high middle income countries, majority of the infants are never breastfed, or 21%, so a larger majority than in low and middle income countries, which is around just 4%. The difference is particularly due to universal ART coverage in high and middle income countries, which reduces the risk of vertical HIV transmission. And while in low and middle income countries, challenges exist such as inconsistent ART access and adherence, making breastfeeding a complication in these areas where majority of the infants are breastfed. In contrast, in high and middle income countries, often they're recommended to formula feed for HIV due to safe and affordable alternatives such as cow-based or soy formulas, while in low and middle income countries, breastfeeding is the economically viable option that saves on these formula expenses. And breastfeeding is also encouraged in low and middle income countries as a protective measure, especially in rural areas where water safety and sanitation are concerns. So taking a look at the global HIV prevalence rates in the last 2 years, I narrowed down to the top 20 countries and found that Southern Africa, consisting of about 2/3 of the HIV global population, bears the greatest burden, with Eswatini, Lesotho, Botswana, and Zimbabwe with the highest prevalence rates. The World Health Organization recommends to navigate this issue by saying that mothers infected with HIV should still exclusively breastfeed their infants for the first 6 months after birth, and then introduce complementary food after that and continue breastfeeding. But besides the transmission risk and the lack of resources and sanitary conditions, some mothers are further confused by mixed recommendations, whether by the World Health Organization or varying success stories of breastfeeding practices among peers, leading to uncertainty and stress. There's also the social pressure for many mothers in low and middle income countries because breastfeeding is a cultural norm, so choosing to formula feed can reveal a mother's HIV status within a community too. And therefore, mothers have to weigh this importance of practicing a traditional form of nutrient giving from mother to child versus the need to refrain from infecting an infant by this practice. So the purpose of my systematic literature review is to provide an assessment of the research done on this topic within the last decade. Yeah, so in terms of methodology, for search strategies, I use these 4 databases: Embase, PubMed, Scopus, and Cochrane databases, where eligible studies included randomized control trials and cohort studies conducted within the last decade, focusing on HIV-positive mothers, whether they had HIV-1 or HIV-2, and published in peer-reviewed journals. The initial search yielded a total of 1,756 articles, and then after removing 493 duplicates, 1,263 articles remain for screening. And then I looked at the title and abstracts for review, where 1,209 articles were excluded for not meeting the inclusion criteria around these concepts over here that I've listed on the left here. And then of the 54 full text articles evaluated, 47 were excluded due to irrelevant or misaligned interventions or lack of focus on infant outcomes, resulting in 7 articles being included in the final review. So these were the 7 articles. These are just some characteristics of the 7 articles that I narrowed it down to. And these were predominantly in sub-Saharan Africa. The sample sizes varied significantly, ranging from 279 infants to 2,092 infants, while most studies focused exclusively on HIV-exposed uninfected infants. 2 focused on HIV-exposed infected and HIV-unexposed uninfected infants for comparison. The primary study designs were prospective cohort studies, with some studies incorporating randomized control trials to assess the effectiveness of varying feeding practices. And then maternal ART coverage varied widely among them as well, where some reported using triple drug ART, which is a highly effective treatment, while others included AZT monotherapy, which is a less effective, outdated treatment, or no ART coverage at all. And then interventions focused on exclusive breastfeeding, which is breast milk only, mixed feeding, or formula feeding, and complementary feeding as well. So the reviewed studies consistently demonstrated that exclusive breastfeeding for the first 6 months, as recommended by WHO, played a crucial role in reducing infant morbidity. And 4 studies specifically emphasized the protective effect of exclusive breastfeeding, showing that when paired with maternal ART adherence, it significantly lowers the risk of adverse health outcomes. For instance, the Jome and colleagues study found that mixed-fed infants had mortality rate of 10.25% compared to just 2.29 among exclusively breastfed infants, with HIV transmission of 20% in mixed feeding versus the 2.7% in exclusively breastfed. And similarly, the Munji and colleagues study demonstrated that each additional month of exclusive breastfeeding reduced the risk of HIV transmission by 18%. So that emphasized the cumulative benefits of sustained breastfeeding. And then 4 studies discussed the risk of formula, mixed, and poor complementary feeding practices. So we see this in the Ajbola and colleagues study, which reported that formula-fed infants had a 4-fold higher mortality risk compared to breastfed infants, primarily due to gastroenteritis and pneumonia. And then mixed feeding also posed greater risks, as well as in the Kamenju and colleagues study that identified that poor complementary feeding practices such as low dietary diversity and infrequent feeding were associated with increased rates of diarrhea, acute respiratory infections, and even when exclusive breastfeeding was practiced initially. So 3 of the studies emphasize the importance of maternal ART adherence as a key factor for minimizing HIV transmission during breastfeeding. As I previously discussed about the Jome study, as well as the GOMA study that highlighted that consistent maternal ART use during breastfeeding kept postnatal HIV transmission rates as low as 4.1%. And then we have the Bork study, which noted that some mothers only received AZT monotherapy, which is less effective compared to ART triple therapy. And then 2 studies also evaluated the impact of breastfeeding duration on infant health outcomes, showing that longer breastfeeding periods, especially when combined with maternal ART, significantly reduced the risk of HIV transmission, as I discussed about the Manji study previously. And then the Marquez and colleagues study found that non-breastfed HIV-exposed uninfected infants had a 13.7-fold higher risk of death compared to the breastfed peers. So in terms of the role of breastfeeding, this review confirmed that exclusive breastfeeding, when compared with effective maternal ART adherence, significantly reduced morbidity, mortality, and HIV transmission among HIV-exposed infants in low-middle-income countries. And in contrast, formula mixed and mixed practices were at higher risk of infant death and infection. And so the systematic review was limited as well by a small number of 7 studies, and this reflects a broader lack of recent high-quality research on breastfeeding among HIV-exposed infants in these regions. There are more studies done in Asia and other parts of Africa on this topic, but those were in countries with much less HIV prevalence, and many of the studies were conducted in the early 2000s. So it was really narrowed down to within the last decade, it is lacking research. And many studies also lacked comprehensive data on maternal viral load and detailed infant ART coverage too. So what could implications for future health policies and research look like? So prioritizing universal ART access for pregnant and breastfeeding women, and adherence support and routine viral load monitoring is essential. And also culturally sensitive breastfeeding counseling should be integrated into maternal health services to address the social stigma around formula feeding. And then future research should definitely focus on long-term longitudinal studies to track the long-term effects of breastfeeding, including more on the role of varying feeding durations, mitigating HIV transmission risk, and implementing these community-based interventions that support both breastfeeding and ART adherence can further strengthen infant health outcomes in HIV-affected regions. So that is my presentation, and I want to thank Dr. Mary Catherine Augustine for my advisor and my reader of my essay, and her valuable feedback really helped me throughout this entire process. And I also want to thank Ms. Christian McCormick for her weekly check-ins and for hosting this presentation. She's been really understanding and helpful throughout this process. And I also want to thank my sister, who's an alumni of our PopFem department, and she taught me how to create the search strategy for this systematic review. Thank you.
Wonderful. Thank you so much, Chamini. So again, I will take questions first from students, followed by others. So while we're waiting for a question, I guess I can ask you one is, what do you think, what was your biggest surprise, I guess, when you did this literature review?
Honestly, I wasn't too surprised about most of the findings because this research stemmed from a previous research that I did in undergrad on just the anthropological aspect of how women navigate breastfeeding and HIV around the world. But what surprised me was the actual lack of research itself, because within the last decade, there's not enough research at all in these areas, especially with higher prevalence rates. And there were so many studies in India, and there were so many studies in Nigeria and Ethiopia as well. But all those countries, they have way less prevalence rates than the top 20 countries that I identified. So had I had an unlimited amount of time or an unlimited databases, if I looked at multiple other databases, then maybe there would have been more research. But I think that research is really lacking within the last 10 years, especially if the rates of HIV are still very prevalent in these areas.
Yeah, that was surprising to me that you only were able to find 7 studies on this. So yeah. Okay, others. Okay, faculty, anybody want to ask other questions? Okay, silence. I'm not seeing anything. So thank you so much, Chamini, for your excellent work and presentation. Really appreciate it. So I will then call Olivia Coffey to the presentation board podium virtually. Olivia comes to us from Wisconsin, Madison's. So she received a Bachelor of Science in Biology and Global Health from the University of Wisconsin-Madison, and her area of interest is women's sexual and reproductive health. So I'm going to let you introduce your topic, your title, and you can take the podium.
Great. Can everyone see my slides?
Yep, this is great.
Perfect. Thank you. All right. Thank you everyone for coming today. Today I'm going to be talking about my essay, Why We Are Afraid of Reporting, a Qualitative Exploration of Barriers to Help Seeking for Intimate Partner Violence Among Kenyan Women. My reader for this project was Dr. Michelle Decker, and funding from the study comes from the Bill and Melinda Gates Foundation. So first, to provide a brief introduction, in Kenya, roughly half of women aged 15 to 49 have experienced physical IPV in their lifetime. Studies show that receiving positive support and help post-IPV experiences is an essential part of the healing process in mitigating adverse health outcomes. Yet there are numerous culturally and contextually dependent barriers that are present for survivors when seeking help for IPV. Therefore, despite increased attention to support services in Kenya, there remains low service utilization and disclosure of violence experiences. Therefore, there needs to be a deeper understanding of these cultural specific barriers to help seeking in order to inform insight into interventions to promote help seeking and strengthen these services. So methods for this study included 60 semi-structured interviews conducted between June and July of 2024, trained interviewers across 4 counties in Kenya, and 15 interviews in each county were conducted in Kakamega, Bungoma, West Pokot, and Kiambu. Participants for the study were selected from a cross-sectional women's quantitative survey that was conducted between May and June of 2024. Eligibility criteria for the study was women of reproductive age, defined as 18 to 45, and currently in a relationship, either married or cohabitating. We also utilized purposeful sampling by education level and violence experience. 3 women were chosen per county per education level, defined as below primary, secondary, and tertiary education levels to provide a diversity of backgrounds and experiences. Furthermore, the semi-structured guide covered numerous topics, including relationships, help seeking, access to justice, access to technology, household roles and decisions, economic abuse, and future plans. After interviews were recorded and transcribed and translated if needed, a team of 5 coders co-developed a codebook using a mixed inductive and deductive approach. All coding was done utilizing Atlas TI software. And to ensure consistency, 10 transcripts were dual coded with different pairs of coders to maximize inter-rater reliability. This was measured by Krippendorf's alpha coefficient. A strong inter-rater reliability was defined as a KCAB of 0.652. Once that was reached, the remaining transcripts were independently coded. And then following this, I conducted a second round of thematic analysis done specifically on our code B6 help barriers, which we defined as perception of barriers to help seeking for safety and violence issues to develop a matrix and identify key themes. So my findings found that barriers to help seeking for intimate partner violence could be conceptualized into 2 categories, interpersonal and community level factors. At the interpersonal level, we found that husband and partner interference, fear of escalating violence, financial dependence on partner, and protection of children were major barriers. And then at the community level, I found that patriarchal gender norms, victim blaming, gossip, stigma, bribes, and distance to help were major factors. So diving into each of these more specifically, I included some quotes. First, at the interpersonal level, fear that violence would increase was a significant deterrent that women in the study had to reporting violence experiences. One woman was quoted saying, "You develop fear, and some, if you report them, that's when the violence escalates a lot. Or even if he hears it somewhere being talked about, the violence will be worse." And then similarly, general husband/partner interference also influenced women's decisions not to seek help post-violence experiences, with one woman sharing that our husbands prevent us because they threaten us, telling us when you go there, don't come back to the homestead. There was a day he threatened me saying, if you go there to report or tell anyone, don't come back to the house. It's the husbands who prevent us from reporting these cases because they threaten us, and that's why we are afraid of reporting. Furthermore, financial constraints were another pathway in which husbands/partners interfered with help seeking for IPV. Some participants reported that they would have nowhere to go if they reported their husband and they relied on them financially. One woman shared, maybe when you're threatened or maybe when you are poor and you depend on your perpetrator financially. So such scenarios prevents you from seeking help. you'll find yourself silent. So maybe you depend on him so much for support, and so you go ahead to report, the support stops, and so you're forced to ignore. Furthermore, another interpersonal level factor that involved family dynamics was the protection of children. Some women said that they feared reporting would result in them losing their children. One woman shared, "I can't leave my kids behind, and I go home alone. That's why we persevere. We persevere just because of our children." So then moving on from the interpersonal level to the community level factors, community norms and ideas regarding gender and roles in relationships played a role in help-seeking behavior. Women reported that in their community, or some women in their community reported that it is seen as a husband's right to hit his wife. One woman shared, "There are those who know that if her husband beats her, that's his right. They say that the husband is the head. Now for her, if she gets hit, she thinks she deserves to get hit." And furthermore, these community attitudes can also manifest in the form of victim blaming for experiencing violence. Some women also reported that IPV is not seen as a serious issue, but rather a domestic problem that stays in the home that is the woman's fault. One woman shared, "I don't report because most of the time in this community, men are always considered right. So listening to my complaints would be pointless. First, they might even shift the blame onto me, saying, I don't know how to handle my husband well compared to his other wives. Secondly, things like fighting between a man and a woman in the household are normal here. In fact, issues like that are considered small and not taken seriously." And then furthermore, some women reported that sharing experiences of IPV was seen as shameful in these communities, and those feelings of shame and stigma would prevent them from seeking help for these experiences. One woman shared, "You cannot share your issues as you will be seen as if you cannot handle what marriage brings about, and you'll be made a laughingstock and also bring shame to your family." Similarly, there was also discussion that there was fear that if they disclose these experiences, it will be shared by others and there will be gossip and mocking them for reporting these experiences. One woman shared, "If I tell someone, they will go and tell someone else, and then they will start laughing at me, and it becomes a story in the area. Sometimes we can go and talk to the village elder of our area, and that's when we get problems, because when we go and tell him, he exposes it to the public. That is the challenges we are going through." So lastly, my last two community-based factors were bribes and distance to help. Bribes were a financial barrier that women faced when seeking IPV help from village elders or service providers. One woman shared her experience saying, "Let's say that you have reported the matter to the chief. The husband might have bribed the chief in order for your reported case not to continue. Hence, this might lead to you not sharing." Some women also shared that if they did seek help, they would be forced to give payment to those service providers, and that was a cost barrier. Another cost barrier was a cost and logistical barrier that was present was distance to help. One woman said, "I have told you that the services available are far away. So sometimes I don't have the fare to get there. Another thing, when you go to people's offices, most of the time they are closed. So it becomes difficult to reach them." So my discussion, previous studies have also utilized a socio-ecological model, but these studies have been mainly conducted in Western countries. While we didn't explore all barriers or all levels of the socio-ecological model because it went beyond the scope of this study expands on the literature by applying this framework to rural Kenyan context to explore what prevents women from disclosing IPV in informal and formal settings. Strengthening these support services is important to address survivors' needs, but without examining these barriers, service will remain inaccessible and fall short of their potential impact. So we hope by clarifying these barriers, this study contributes to our understanding of how to better connect survivors to improve their safety, health, and well-being. This evidence also suggests that community-based interventions, potentially targeting stigma and social norms, may also have a potential impact on help seeking and not just preventing violence in general. There are a few limitations of this study to note, mainly a small sample size and limited generalizability. So these findings may not be representative of the broader Kenyan population as a whole. But with that being said, in conclusion, without a deeper understanding of barriers to help seeking, survivors or services are unlikely to reach their full impact for survivors and those at risk. Further exploration is needed into this topic for developing culturally responsive interventions for IPV, such as those culturally based or community-based interventions I previously discussed, to meet the needs of all survivors. And lastly, I just wanted to take time to acknowledge my reader, Dr. Michelle Decker, for her mentorship and guidance, as well as the rest of the Agile study team, my preceptor and program officer, Salma, and then other coders, Mercy and Judy. I also wanted to acknowledge the women in the study who are willing to share their stories with me. So with that, I have my references and
Fabulous job. Wonderful. This was so interesting and sobering at the same time, but really important work. So I want to open it up for questions. Hopefully we'll get a question from a student. Okay, you guys are very shy today, huh? Well, I'll have another question then. So I'm wondering if you could tell me, I don't know if you had a chance to look at this, but you did a purposive sampling, and I was wondering, did you see any differences, for example, by education level or even by the county? Did that factor in to how they responded?
I didn't do an analysis specifically on that, but anecdotally, I can say that findings were pretty similar across education level, and other than maybe details of responses, findings were pretty similar across the education category and county level.
Okay.
From my perspective.
Okay. Other questions? Haley.
Thank you. Great job, Olivia. I just wanted to ask you if you could talk a little bit about working with your Kenyan colleagues and how doing that dual coding, how that process went, and what sort of learnings or like contextual factors were they able to speak to help you think more about your findings, since those women are from that context?
Yeah, that's a great question. It was great to work with them. I think I primarily communicated with Salma, but I think they brought a good perspective to the team when we were doing those dual coding process. There was a lot of shifting that had to do with the code book as we moved through the process. And I would say they were the ones that were mainly providing that insight about where adjustments could be needed. And yeah, it was really great working with the whole team. I thought the process went very smoothly. Yeah.
Olivia, do you know how these findings going to be shared with the communities, or what's the next steps with that?
They were shared with Kenyan colleagues already. Yes, their Ministry of Health, I know, was the findings for the quantitative survey and the qualitative survey have started to be shared.
Great. Yeah. Really important work. Any other questions? We have time for one more. Okay. Well,
I have one.
Oh, great. Aris.
Hi.
Yes.
Hi, great work, Olivia. Yeah, in the same vein of like sharing the results and disseminating, I mean, you talked a lot about interpersonal factors and cultural factors that prevent these women from reporting. So how do you think, like, what are next steps in kind of raising these concerns and just helping women, I guess, I don't want to call them barriers, but, you know, kind of get past these things and able to report, you know, domestic violence?
I can't speak to what happened at like dissemination events, but I can say my perspective. Like I talked about, I think a lot of times in this field, interventions are focused on prevention, but I think those same like community interventions could also influence help seeking and help seeking response. I think that's true everywhere. Like knowing how to respond to IPV is just as important as preventing it. So I think using these to inform those kind of community-based interventions would be really important.
Thank you.
Thank you so much, Olivia, for this wonderful presentation. Really appreciate your work. So
thank you.
I am now going to call our final presenter, Elena García Fariña. So welcome. You can start to, oh, look it, you're already sharing your slides. So thank you. Elena has a Bachelor of Science in Human Physiology from Boston University, and her area of interest is women's sexual and reproductive health, and she will also be presenting a qualitative research study, as you can see. So Elena, why don't you take it away?
Perfect. Good afternoon, everyone. And thank you, Dr. Murray, for the introduction. I'm excited to present on the amazing work I conducted as part of my field placement, exploring determinants of family planning progress within Bolivia, which was chosen as an exemplar in global health. I had the pleasure of leading this qualitative case study in collaboration with my advisor, Carolina Cardona, and in-country partners. Background: why Bolivia? Bolivia is a lower middle income country in Latin America, which increased its modern contraceptive prevalence rate, MCPR, from 12% in 1989 to 45% in 2016, achieving an average 5% annual growth rate. Bolivia was selected as an exemplar through a data-driven process that assessed MCPR and demand-satisfied trends adjusted for development level and prioritized countries with equitable gains across population subgroups. Another important background characteristic to consider is the geographical differences within the country. Bolivia is divided into 3 geographical areas: highlands, valleys, and lowlands. Interestingly, poverty lines follow geographical differences, with higher poverty percentages concentrated in the highlands, shown in figure 2 in red, and lower poverty percentages concentrated in the lowlands, shown again in figure 2 in green. MCPR trends are also in alignment with geographical differences, with the highest modern contraceptive prevalence rate in the lowlands here in darker red. These geographical differences have been at the center of our data collection methods and data analysis strategy. So the research question at hand is, what are the social, economic, and political determinants that contributed to 1, the increase in contraceptive usage and uptake, and 2, the reduction in socioeconomic related inequalities in the contraceptive usage and uptake along the timeframe of 1990 through 2024? Methods. We conducted a qualitative analysis to answer this research question. Participants were recruited to focus group discussions through Mary Stopes International Bolivia, using stratified sampling by region, age, and gender, enabling us to capture diverse perspectives. 20 focus groups were conducted in Spanish between July 2023 and March 2024. All 20 focus groups were recorded and transcribed verbatim for analysis. And the sessions followed a semi-structured interview guide covering education, community norms, access, and health systems experiences. We developed a multidimensional qualitative data analysis plan to ensure a rigorous and systematic approach, which included 5 steps. We also used Atlas TI to facilitate data management and organization. Okay, first step, we constructed a comprehensive data inventory to organize available data for analysis, and this inventory served as a foundation for data triangulation, enhancing the credibility of our findings. Second step, 6 focus group transcripts were selected, representing both female and male conversations across 3 distinct geographical areas. This decision was also supported by the differences in MCPR across these regions recorded in the 2016 National Health Survey that I showed in the previous slide. Importantly, we achieved saturation within these 6 transcripts. Third step, I constructed 6 episode profiles from the selected focus group transcripts, capturing the most salient quotes and using analytical memos to document key discoveries and suggestions for inductive codes. These analytical memos played a crucial role in maintaining the dependability of our analysis by providing a transparent trail of our analytical decisions. Fourth step, the episode profiles and memos were reviewed collaboratively by Carolina and I, which informed the inductive codes from our initial codebook. And last step, we applied the codebook to the to the selected initial focus group transcripts, the analysis followed an iterative approach with weekly meetings to discuss code applications, emerging codes, and findings. 4 codebook versions were created, and here you see the most salient are the thematic codes that we included in the final codebook. And we brought in an additional team member, Leandra, to further test the reliability and dependability of the codebook. And finally, all 20 transcripts were coded. Results. Our analysis was structured around the socio-ecological framework of public health, like Olivia's, recognizing that health behaviors are shaped by multiple levels of influence, including individual, interpersonal, community, and institutional factors. The next slides will highlight major patterns that emerged from the focus group data, exemplified by key codes and quotations. Within the individual level factors, education and women's empowerment emerged as key codes. Despite growing gender equality in education and employment, women continue to shoulder disproportionate domestic responsibilities, reflecting persistent structural inequities in household labor. One of our participants shared, I say that if there's equality, what there's not is a facility for men and women to study equally. What parents want is for both to study and have a job. But the difference between men and women is that men study, work, and get married. However, women have to study, but at the same time, take care of your brother, cook, and clean all at the same time. That is, there's equality, but there's no facility in both terms. At the interpersonal and community level, shifting social norms and peer influence were essential. Conversations with friends, partners, and community health workers helped reduce stigma and normalize contraceptive use. Still, in rural, indigenous, and pronatalist communities, traditional expectations and fear of judgment persisted, highlighting the uneven reach of norm change and the importance of community-based education. When looking at the acceptability and knowledge of family planning piece, one of our participants shared, I think there's more information than before. Women especially have more access and know where to find methods. Looking at the intergenerational shifts and gender roles, now young women are acquiring a different mentality. There are institutions that help. Education in terms of gender has improved. And area of residence, there's a complete rejection of access to contraceptive methods in communities outside the urban area. Finally, at the institutional level, NGOs were not just filling service gaps. They were preferred over public clinics for offering higher quality, faster, and more respectful family planning care. One of our participants in sharing about the role of public health sector and NGOs said, with civil society's contribution, we are strengthened. The prevention campaigns promote methods like implants and condoms. Then looking at quality of care, they shared, they always organize outreach campaigns, the NGOs. In those campaigns, service is better than any other clinic. They have their laboratories and all that. So here in the public sector facility, if I go, I won't even get a pap smear. I won't even get it in a month. So that's why I do not choose to go there to the public facility. Implications of our findings. Bolivia's experience aligns with global family planning literature, showing that education, strong social networks, high quality care, and supportive policies drive contraceptive uptake. While Bolivia's progress supports these global findings, it also adds important insights from a locally driven trajectory of change. Interestingly, progress continued and even accelerated after the 2013 departure of USAID, defying concerns about donor withdrawal. NGOs were not only gap fillers, but preferred by participants for their quality, counseling, and trustworthiness. And finally, gender equality is advancing, but remains constrained, with women increasingly expected to work outside the home while continuing to shoulder most domestic responsibilities. To quickly conclude, I will read our 5 key takeaway points. So Bolivia's success in family planning was not driven by a single factor, but by aligned efforts across education, health systems, policy, and social norms. Empowerment of women, improved service quality, and inclusive policies created an enabling environment for contraceptive use. Community trust and NGO government partnerships played a critical role in expanding access and quality of care. Progress is not automatic. It requires sustained political will, inclusive development, and attention to structural inequalities. Finally, Bolivia's experience offers actionable insights for other lower middle income countries aiming to build equitable, people-centered reproductive health systems. I had the fantastic opportunity of presenting my findings at the Johns Hopkins Program in Latin American, Caribbean, and Latinx Studies Research Symposium, the Population Association of America Conference last month, and this collaborative country case study has been submitted for publication at BMJ. I will also be working to publish these qualitative findings. Finally, I wanted to take the opportunity to thank the Program in Latin American, Caribbean, and Latinx Studies at JHU for the Summer Fellowship Grant and PFRH's Master's Essay Review Committee for my Distinction Award. And the biggest thank you goes out to my fantastic Master's Advisor and Faculty Reader, Carolina Cardona. I've learned so much from her, and I'm so grateful for her guidance and support throughout these 2 years and for the opportunity to work with her on this special project. Thank you to our in-country partners, Sustainable Development Solutions Network Bolivia, Mary Stopes International Bolivia, and to the Exemplars in Global Health Coalition. Thank you to my amazing Department of Population, Family, and Reproductive Health for all of the support offered over this program and for investing in faculty who represent the diversity of the students and the populations we serve. And last, but certainly not least, thank you to my family and friends for supporting me along this journey. Here are my references, and I open the floor for questions. Thank you, everyone, for listening.
Oh, I love it. I love the photos. Great job on this presentation. So I will open it up to questions. Do we have any questions from students? You can type in the chat if you'd like. So I guess, Elena, I will go ahead and ask you, well, this was such an interesting presentation. I'm wondering too, since you had different focus groups from different areas, I'm wondering if you could talk a little bit about some of the differences that you saw within those areas.
Yes, thank you for that question. Well, it's very interesting. Again, like drawing back to the geographical differences, like all of the findings align with us, the MCPR, the poverty lines, and also sort of the acceptability. So seeing the lowlands with lowlands and valleys also had urban areas, but sort of lowlands were higher MCPR. That aligned with sort of our findings of just more openness, more trustworthiness, trusting in the public system and the NGOs, and then the high impact that the NGOs had not only like throughout the country, but especially in the highland areas, some of these areas that are harder to reach, rural, pro-natalist, indigenous, like the real impact that the NGOs were able to make with like mobile clinics and those kinds of things.
Mm-hmm. Yeah, that's what I was thinking. Yeah, thank you. And a follow-up, I guess, is are there going to be different ways of kind of addressing some of these disparities within these areas?
Yeah, I think that's a great question and something that should definitely be taken into account in minimizing inequities, right? I mean, one of the slides that I wasn't able to share is actually the reduction in like inequities through like socioeconomic status, wealth quintiles, and community, like throughout the community.
Mm-hmm.
But definitely, I think addressing sort of those gender norms, those differential gender norms, expectations, and openness to contraceptive use, especially in those highland, rural, indigenous communities, would be a great strategy.
Mm-hmm. Definitely, yeah. Okay, other questions? Students, faculty, others, family members, anyone is welcome. Okay, well, I'm not seeing any questions or hearing from anyone. So Elena, I want to just thank you for this fabulous job. And I want to thank all of the wonderful presenters today. This was just a fabulous session, and I want to thank the readers. And I also want to give a special shout out to Krista McCormick, who really helped facilitate and organize this session. So thank you all for all of your hard work, and it really showed. So until next year.